think we can start today's proceedings, and we have with us now for today's session. We have two very eminent pediatricians. One is the speaker and one is the chairperson. So from Africa, two lead pediatric nephrologists from Africa. So Dr. Francis is a very renowned and very well-known academic pediatric nephrologist from Tanzania. And today we have the pleasure of him moderating the session. And of course, Dr. Francis will introduce Professor Bhimma, and then we'll take it on from there. Over to you, Dr. Francis. Thank you so much for coming on today.
Thank you very much, Dr. Lloyd, and I'm sorry for a bit of my delay. So may I take this pleasure, without further ado, to introduce Professor Bhimma. Professor Bhimma is a renowned professor of pediatric nephrology from KwaZulu-Natal University, and he is widely published, and I believe we all had an honor to have his talk on hypertension, which was about last month, I think, or this month. He has done a lot of work in pediatric nephrology and nephrology in large. He has published several books, and he's done a lot of work in the area of nephrology. He's the chairperson of, I think, of the Kidney Transplantation Committee in KwaZulu-Natal. So may I, without wasting time, welcome Professor Bhimma to grace us with this important talk of childhood urinary tract infection. Welcome, Professor Bhimma.
Thank you very much, Francis, for that introduction and for everything. Look, today I'm going to speak on a topic which I must tell you is one of the most controversial topics in pediatric nephrology. I don't know what it is in adults, so it's the easiest but the most controversial. So what I'm going to do is I'm going to run through the slides, and please, if anyone has any points of clarity or want to make any comments, etc., please feel free to interrupt me during the course, because I'd like this to be interactive session rather than a didactic lecture. You know what I mean? Okay, so let me just start to share my slides, and then hopefully you'll be able to see everything. Okay, so, you know, the good thing about life is that when we are born, we are totally innocent, and we are in this wonderful bubble wrapped by our parents, etc. And there is this ray of this rainbow, which the parents tell you that as you grow up, you'll have a pot of gold at the end of it, and we all are seeking that, right? And that's how life starts off, okay? And as you grow up, you're pretty carefree until you get to the stage where your hormones start to develop, and this is what you see, okay? So two people who are starting to fall in love, okay? Of course, hopefully that's going to lead to marriage. And when you get married, the end product of that is you have a lovely baby that is born, okay? And the parents are very happy. But alas, life is not always the same, and baby might end up being like this. And if that is persistent, then you're going to end up with this, okay? So that brings me to my topic. What is one of the possible causes that might cause a child to become so irritable and gives the parents a hell of a time so that they end up shouting at one another? And that is urinary tract infections in children, okay? And today we're going to discuss the topic not just in children, but also to some extent in adolescents, although I'm just going to touch on that. So that's a bit of overlap between our colleagues in adult nephrology and the pediatricians. If we look at urinary tract infections, they are characterized by pathogenic invasions and replication of these pathogens in the urinary tract. So that's what it is, right? And in childhood, it's the second most common infection after otitis media. And if you look at the prevalence, by the age of 7, about 8% of girls and 2% of boys will have at least one episode of urinary tract infection. That is a considerable number, okay? So 8 out of 100 girls and 2 out of 100 boys, and that's something to say. And if you look at it, 20 to 30% will develop recurrent infections, okay? And of course, we treat this with antibiotics, and antibiotic resistance to uropathogens is steadily increasing because of its increased use, but also of its abuse, okay? And the thing about it is that in infancy, urinary tract are commoner in boys. That means from birth to 1 year of age, right? But thereafter, the table reverses. So it becomes more common in girls than it is in boys. Now, how do you diagnose a urinary tract infection in a child? This was a question that I was asked by one of my primary healthcare physicians. He is a family practitioner. So I told him, it's only, he said, if I see a dipstick, can I diagnose a urinary tract infection? So I told him, no. The only definitive diagnosis is based on culture of an organism and in the urine, okay? And usually it has to be a single organism, right? If you get multiplicity of organisms, it usually suggests contamination. However, there are rare instances when you can get more than one pathogen, but I'm not going to go into that for this talk, okay? But not only must you culture this organism, the amount of organisms that are present in that urine also determine whether that culture is significant or not. And the amount of organisms depends on the way that you collect the urine, okay? So if you have urine in a child that's collected in a young child, in infancy, that's collected, say, by a suprapubic aspirate, then any growth is considered to be significant, right? Right? If the child has greater than, okay, sorry, if the child has greater than, if the child has greater than 50,000 colony-forming units per mole, or if less, if there's fever and leukocyturia, once again, is significant. Now, the Italian consensus statement on this is that you should have greater than 10,000 colony-forming units. I took this from the Italian consensus statement, okay? So in our setting, if I find one of my staff has done a suprapubic aspirate and I find any growth, provided the child has other symptoms of a urinary tract infections, then that I will consider to be significant. The second best method of collection is a transurethral bladder catheterization. And here, if you find more than 50,000 colony-forming units per mole, or if the child has a fever and you got leukocyturia in the urine, and there's more than 10,000 colony-forming units per mole, then that is significant, okay? If, on the other hand, you do a clean voided urine specimen in a child that is continent, that means an older child, and provided you instruct the parent properly how to collect the urine, etc., and it's not left standing around for a long time, then greater than 100,000 colony-forming units per mole is significant, okay? And the last method of collecting, which is unfortunately the most common, but the method that we shouldn't be using, okay, because it is prone to contamination and prone to false positive results, etc., is by bag specimen, okay? You ask any of the staff in pediatrics, both in my hospital or I'm sure in your hospital as well, that you wanted a urine specimen sent to the lab for culture. All they will do is slap a bag onto the child's perineum and to the child and wait for the child to wee and then collect that urine and send it off. The problem with bag specimens, as I said, is prone to contamination, and it is strongly discouraged that you collect urine that way. So the best method of urine collection is suprapubic aspirate. So let's discuss this, right? In infants and toddlers, bladder catheterization suprapubic aspirates, as I said, is the best method of collection. However, the problem with that method of collection is that although it's the gold standard, it's not always feasible as a routine procedure in primary healthcare settings. You need a fairly skilled individual to do it because you are inserting a needle into the child's bladder and you can traumatize other organs, you can cause bleeding, or you can, and it is something that is painful to the child, okay? So you don't want to do it unnecessarily unless you strongly suspect UTI, urinary tract infection. Now, midstream urine is the preferred method if the child is cooperative because it's not invasive, and provided the child has established bladder control and the parent is properly instructed, the nurse is properly instructed how to do it, then it is the recommended method, especially in primary healthcare settings and in a busy hospital setting, in the outpatient department. Now, to get urine, if the child is not continent, but you still want a clean specimen, you can do what is called bladder tapping or sacral massage, which is non-invasive stimulation, and that triggers the child to pass urine, okay? But you have to be pretty slick at this because you have to have your sample bottle ready, so that the moment the child passes urine, you collect that, right? And as I said, urine blood collection should not be used because of the high risk of contamination, okay? And it is not recommended. So given take that bag specimens are not used, the best method of urine collection, which is non-invasive, is still clean voided urine catch. And if you can't get that in a child that is not continent or not cooperative, etc., then you do what is called an in and out catheter, 10 transurethral bladder catheterization. Okay, so if you want to do a suprapubic aspirate, what I usually do is I get the ultrasound machine quickly, and we have one fortunately in our unit, and then I ask one of the staff to bring the child after it's fed, and you do an ultrasound. You can see the bladder, and you can, under ultrasound visualization, you can then aspirate the bladder. So in that way, after you put some local anesthetic onto the child's abdominal wall, in that way it is invasive but less traumatic to the child. So you know that you're definitely going to get urine, okay, and not damage any other organ that while you are doing the aspirate. What are the common types of urine pathogens? Similar to adults, we see E. coli in children, and that makes up over 85% of the organism that you see. Other organisms are Klebsiella, Proteus, Enterobacter. Proteus is slightly more common in males than in females. Citrobacter, Enterococcus, and of course, Staphylococcus saprophyticus, not Staphylococcus aureus, okay? So those are some of the common uropathogens that we will be seeing, right? Now, just before I go on, and this was a review paper that I did for this journal, Advances in Pharmacoepidemiology, not a very great journal, but they asked me to write a review for some reason. And one of the things that you'll come across are the different classifications of urinary tract infection. Now, I'm not going to go through this in great detail because that's a lot, and you can read it later in the slide. But basically, urinary tract infections are divided into what we call simple and severe, and complicated, uncomplicated. Now, complicated is when you have infection patient with an abnormal structural or functional urinary tract, or both. That means there's vesico-ureteric reflux, or there's some type of congenital abnormality of the kidney, and this child presents with urine. That's called a complicated UTI, right? Whereas uncomplicated is when you get a urinary tract infection in a child who's otherwise structurally and functionally, has a structurally and functionally normal urinary tract. And then you get what is called simple and severe urinary tract infections. And that's whether there's lower urinary tract involvement or upper the kidney involvement, okay? And of course, in adults, and older children, you just get bladder infection, and that is a straightforward cystitis. And in the older child, say a 10 to year old above to adolescent, if they get all the symptoms of a lower tract infection, burning, frequency, low abdominal pain, etc., that's a simple cystitis without any fever, okay? Then you get recurrent urinary tract infections, and that is defined as 2 or more episodes of urinary tract infection with acute pyelonephritis plus 1 episode of urinary tract infection with acute pyelonephritis plus 1 or more episodes of urinary tract infection with cystitis or lower urinary tract infection, or 3 or more episodes of UTI with cystitis or lower urinary tract infection. Now that's a mouthful, okay? And I looked at the definition, and I found one of my colleagues who's an expert, and I said, why did you use this definition? He says, well, that's what they settled at, you know what I mean? Because it was very difficult otherwise to define recurrence. But I would just say recurrence is when you have a urinary tract infection that is treated, the child on subsequent testing is negative, etc., and then you get a urinary tract infection, but it doesn't matter whether it occurs with the same organism or not, it is the child being completely cured, right? Relapsing urinary tract infection, on the other hand, if you have prompt recurrent of infection with the same organism, the moment you treat the child and within a short period, within 7 days, the child gets another infection with the same organism, then that's relapsing UTI. And you saw me, that's the definition that we should be using, okay? That hasn't come out yet, but they're still working on it. And then there's this entity which I don't know how many of you are familiar with, and I wasn't familiar with it until my own nephew developed this, and that's called acute lobar nephronia. Now, this is a type of infection which behaves unusually, in that the kidney, there's a whole lot of inflammatory cells in the kidney. If you have to just see massive infiltration neutrophils, okay? But it forms like a mass. It's not an abscess, but it forms like a mass in the kidney. And when you do imaging, either ultrasound or CT imaging, the radiologist thinks it's a tumor in the kidney, okay? And these children are pretty sick, okay? And these are the type of ones that often end up having a biopsy or laparotomy or whatever it is. And in fact, it is just a simple UTI, but they respond with intravenous antibiotics and they take a bit of time, right? And those are the ones you have to treat with a full course of intravenous antibiotics for at least 14 days. So that's an entity which is there, and there are some very published literature on it. I just reviewed 2 years ago an article by the Chinese who had a collection of about 14 cases of this and over a 10-year period. So it's not uncommon, okay, especially in childhood. So that's something you'll come across. Now, what is the role of, what is the role of urinary dipsticks in the diagnosis of urinary tract infections? Now, dipsticks are not there to give you a definitive diagnosis. They are good for screening, okay, and that's important. And many of the primary healthcare physicians, unfortunately, use dipsticks as a definitive diagnostic test for urinary tract. So if they find leukocytes or they find nitrites, then they will diagnose a urinary tract infection. That is not true, okay? It's a screening test, okay? Now, this is a study that was done, sorry, I forgot to put in the reference, but that looked at the sensitivity and specificity of dipsticks. And I'm not going to go through everything in detail, but just to tell you that if on your dipsticks, you find nitrites and leukocyte esterase positive, you got an 88% sensitivity and 80% specificity of having a true urinary tract infection. So it's quite sensitive, right? If you got both positive, then you got a 98% specificity and 45% sensitivity. Now, I don't know why the sensitivity was so low in this study. It's much higher in other studies. But if you have leukocytes or nitrite positive, the sensitivity is high and the specificity is about the same. So this test is quite useful, okay, and a screening test. And I often use it if I get a child who's suspected of urinary tract infection, and I just want to screen the child to see whether it's a urinary infection or must I look elsewhere, then here it is okay for you to do a bag specimen and use the dipsticks as a screening test, okay? Now, there's a problem in young children, okay? The problem is in young children, they tend to have very frequent voiding because the bladder is small, okay? Now, when the bladder is small and the urine is not in the bladder for a prolonged period of time, what happens? There's not enough time for inflammatory cells to collect, etc. So when you do a dipstick, your leukocytes and of course nitrites are from the breakdown products of bacteria, okay, the enzymatic product. So you don't get a positivity on that. And then certain types of bacteria like enterococcus, etc., can contaminate the perineum, and also you might get either false positives or false negatives. Fever itself can result in leukocyturia. So the finding of leukocytes in the child who's got a high fever on the urine dipsticks without nitrite doesn't necessarily mean that the child has a urinary tract infection, but it's a good screening test. Always, once again, I'm to emphasize that you have to culture the urine. And remember, when you send off urine for culture, you have to inform the lab that you're sending urine, they must culture it immediately. No point in the lab you leave it standing around. If you can't transport the urine immediately, always refrigerate the urine so that there is no bacterial contamination due to the heat. Then how do you interpret findings on urine dipsticks? Okay, I went through this partly that if you have nitrites positive and leukocyte esterase positive, it is very likely, as I said, right? But of course, you must form a urine culture immediately. If the nitrites are negative, but the leukocyte esterase is positive, it is likely, but not as likely as if you have both positive. However, if both are negative, then it is unlikely that you have a urinary tract infection, except, as I said, in very young children, okay, where they have very frequent voiding. So the thing is, if you get this in an older child or adolescent or even in an adult, if you strongly suspect a urinary tract infection, still send off the urine for culture, but always look for an alternative source for that infection, okay? Because it may not be a urinary tract infection. Now, when do you suspect a UTI in a child or adolescents? The most common presenting feature is fever, greater than 38 degrees, obvious. Remember, in young children, once again, especially those that in the infant phase, 2-3 months old, you might not find fever. Okay. The other thing is malodorous urine. Now, if you look at malodorous urine, in my experience, this has been quite a sensitive test. Now, parents will come and tell you, doctor, I think my child's got an urinary tract infection again, or bladder infection again, or kidney infection again. And you say, how do you know that, mom? Did you have the urine cultured in the lab? She says, no, the smell of the urine that on his nappy is different. Right? So she said, the smell of the urine, doctor, is very different. So this, and I have not found this to be false in many cases. In fact, I can't recall any incident where it's false. Okay. However, the literature doesn't give it a high specificity or sensitivity for some reason. Poor growth, which is failure to thrive, especially if you have chronic urinary tract infections. And then, of course, children with chronic kidney disease always have a higher incidence, so you must consider UTIs if they present with fever or other signs. And then in malnourished children with fever, abdominal pain, and other signs of lower urinary tract infection like burning or frequency, that's how they will, you would suspect it. Now remember, malnourished children are very prone to develop urinary tract infections, especially children who present with gastroenteritis. Okay, the gastroenteritis may not be a true diarrhea, it may be a parenteral diarrhea. So when you get a child presenting with diarrhea, but it's has a high fever, etc., always culture the urine, because we did a study in Durban and Prof. Dina did it, and he found that the incidence of UTI in his children was over 30%. So depending on the age of the child, what are the common symptoms that we find? Like I said, in the newborn period, the commonest is fever, right? Other things that you might find are vomiting, irritability. Jaundice is another presenting symptom, okay? Especially if you have prolonged neonatal jaundice, always exclude a urinary tract infection. And of course, if you're having recurrent attacks of urinary tract infection, the child may have failure to thrive. Now, in young children who are not toilet trained, the other things you find are irritability. They might complain of abdominal pain. And then when you examine them, you may or may not find suprapubic tenderness, okay, depending on the age of the child and how cooperative they are. But less common, and they say less common, but I think it's quite common, is this malodorous urine, okay? The mother is always aware that this urine odor has changed, and she will tell you that, you know, I think my child got another attack of urinary tract infection. And then, of course, you may sometimes get frank hematuria, but that's not very common, okay? In older children who are toilet trained, they usually present with features of cystitis, so they get dysuria, they may get voiding dysfunction. Now, what is the voiding dysfunction that you see commonly? You commonly see what is called bedwetting, okay, enuresis, okay. Then other features of pyelonephritis will be fever, vomiting, dysuria, and abdominal or flank pain, right? And of course, if they have a high fever, etc., one of the things that they'll present with is malaise. So those are some of the common symptoms that you see of urinary tract infection, depending on the age of the child, okay?
Crazy.
Now, what about anatomical and functional anomalies that may be associated with an increased risk for urinary tract infection? So, okay, I think someone's on the call. So let me just put this light on.
I've muted everyone, don't worry.
So the two common ones that we see in our population are vesicoureteric reflux and what do you call it? Posterior urethral valves with a neurogenic bladder. So those are the ones that we commonly see. Now, vesicoureteric reflux, for some reason, is not so common in our Black population, but we see a fairly high incidence in our Indian and Caucasian population, okay? But in our Black population, previously, we used to see a lot of urinary tract infections, as I said, associated with parenteral diarrhea and malnutrition, okay? But nowadays, we are starting to see more and more patients presenting with neurogenic bladder who have urinary tract infections. So some of the things that predispose to lower urinary tract infections are like, as I said, posterior urethral valve, erythrocele, which is uncommon, but VUR, vesicoureteric reflux, is quite common. patient that you're dealing with, and other congenital abnormalities of the kidney and urinary tract, like ectopic ureters, and then, as I said, neurogenic bladder and bladder outlet obstruction. If you look at upper urinary tract abnormalities, sometimes we have cystic kidney disease and duplex kidneys or horseshoe kidneys, and then you get uretero-pelvic junction obstruction. So those are the things. Whenever you have CACUT, CACUT is the acronym for congenital abnormalities of the kidney and urinary tract, we have that. So we see that we will always find that we might find a UTI. So always suspect it in that setting. So what are some of the issues to consider in the history and physical examination? Always ask about the duration of symptoms, about the drinking and voiding habits. Now, why do we want to know about drinking and voiding habits? Children tend, especially small, younger kids, between the ages of about 3 to about 5, they get busy with play and they will hold the urine until they've reached a stage where they can't hold any further, and then they say, "Mom, I need to go." You know what I'm saying? And that holding of the urine leads to a large bladder volume, and what happens is they get reflux, okay, and that can lead to predispose them to recurrent excessive UTI. History of constipation. I cannot emphasize this. You must take a history of the bowel habits. Right? Constipation is a very, very important factor that predisposes to urinary tract infections in children. Okay, and often it is not very forthcoming. Okay, and if you ask a parent, does a child go to toilet normally? Does it pass stool normally? And the mom says yes. But if you observe these patients, they pass a very small amount of stool. Okay, and usually it's just in the form of pebbles if they're severely constipated, or the small amount of stool. And if you do an X-ray, you'll find these children are constipated. So constipation cannot be underestimated. Always think of that when you have a child, especially with recurrent UTIs. Sexual habits in adolescents, okay? Remember, in adults, this is one of the commonest causes of honeymoon cystitis, etc. I've picked up quite a few of my adolescents who have recurrent attacks of urinary tract infections, and you ask them, but you've never had this before, and then until the nurse whispers to you, you know what, I think she's got a boyfriend, okay? So they are sexually active, okay? The other thing is a urinary tract infection, in particular in female children, may be the harbinger of sexual abuse, okay? So always keep that at the back of your mind, okay? That if you get a child who's got urinary tract infections, you might find that they have been sexually abused. So they might not volunteer the information, but just keep it at the back of your mind and have high index of suspicion if you find other telltale signs of sexual abuse. Circumcision in males. Okay, it's been shown that if you have circumcised males, they are less likely to have urinary tract infections, but studies have shown that you need to do at least 500 male circumcisions before you can prevent one attack of UTI. So although it's something that if parents ask you about, you tell them it's good to do, but it's definitely not something that you should force them to do, because there's not good literature to show that if you circumcise a child, they will not get a UTI. You need to do about 500 to prevent one attack. Swimming is another very important predisposing factor, especially if children are using public swimming pools, etc. Okay. Then you want to find out the number of UTIs. Of course, as I discussed, you have recurrent urinary tract infections. The age of onset, the younger the age of onset, the more likely are you to find CACUT. That means some type of congenital abnormality. Okay. Of course, if you have CACUT that's documented prenatally, that means on fetal ultrasound. Okay, nowadays we have fetal ultrasonography, particularly in our patients in the private sector, and many of these CACUT is discovered when they do antenatal scanning, and then the obstetrician will inform you that, look, this child has this kind of abnormality, please do postnatal imaging, and if you do that, you can follow up the child. And many of the children who have severe VOR or have posterior valves, etc., may present with urinary tract infection. History of previous surgery to the urogenital tract is another predisposing factor. And in some populations have family history of urinary tract. I've never found this to be in our population, but it's documented that if you have a family history of urinary tract infections, then it may be Those are some of the important things that you'll take into consideration for in the history about and physical examination of the children with UTI. Another thing that's asked is, do you have to do blood tests to diagnose the urinary tract infection? The answer is no. Blood test doesn't diagnose the urinary tract infection. The only however, you might do blood tests in hospitalized children who are severely ill, who have what is called urosepsis. That means they are toxic and ill with septicemia, right? So, and it's recommended, especially in young children who are less than 3 months old, as I said, with urosepsis. And some of the things, type of blood tests that will help you are like the full blood count, looking for a high white cell count, inflammatory markers like C-reactive protein or procalcitonin. And of course, you want to look at the kidney function test because you want to know, does this child have any evidence of kidney disease, okay, or compromised kidney function. When should a child be hospitalized with a urinary tract infection? Usually, if the child is not severely ill, etc., or has got just symptoms of lower urinary tract infection, there's no need to hospitalize the child, okay? You don't need intravenous antibiotics. I'll discuss this just now. But if the child is quite ill, that means got quite severe urosepsis with toxic looking and or may have shock or is dehydrated and has pernicious vomiting, then definitely those children need to be hospitalized, right? Another factor that we don't take into consideration is non-adherence, okay, especially in children who have recurrent urinary tract infections. I've had one case of this where this patient, you will take the medication, but she will go to the bathroom and she'll spit it out, okay? And I kept wondering, why is this child not getting better? Because you're giving the appropriate antibiotic and the child should have responded. And the problem was the mother then caught the child being non-adherent. So if you have non-adherence, it's better to hospitalize the child and treat the child with intravenous antibiotics, okay? You know it's definitely going in. And of course, if you are using appropriate antibiotic treatment and the child has a fever for more than 72 hours, which is still not settling, then once again, you need to admit this child for intravenous antibiotics. So those are some of the rare indications where you need to hospitalize these children. In adults, it's easy, but in children, it's very difficult in a very young child to differentiate between upper and lower urinary tract infections, right? Now, just to remember that lower urinary tract infections are particularly common in girls over 2 years of age. As I said, in infancy, UTIs are much more common in males than in female. However, when they get older, it's much more common in females. So if you have a patient who's a female child over 2 years of age, and they presented with mild fever, but may have vague abdominal pain, etc., it may just be a simple cystitis, right? The other thing is, in the older child, is absence of fever and loin tenderness, okay? One of the markers, the clinical markers. And of course, if they have inflammatory markers that are low, okay, low CRP, low procalcitonin, usually suggests lower urinary tract infections. And of course, if they have classical signs and symptoms of a lower urinary tract infection, then the diagnosis of the older child is obvious, okay? So those are some of the things that will help you differentiate upper from lower urinary tract. Now, how do you treat once you've diagnosed the urinary tract infection, okay? So you've done a dipsticks, you found nitrites or leukocytes or both positive, etc. You suspect a urinary tract infection, you take an appropriate specimen, whether it's in and out catheter, that means what you call it, clean catheterization, or you do in a very young child a suprapubic aspirate under ultrasound guidance, or you've done a clean catch in an older child who is continent. You want to begin treatment. Now, treatment of the child depends on certain things. In other words, I gave you some indications when you'll hospitalize the child, when you will not hospitalize the child for intravenous antibiotics, but some of the things that you have to also consider, what's the age of the child. If you have a child that is very young, that means less than 2 months old, I would strongly suspect, I would advise that you actually admit the child for a few days of parenteral antibiotics until the fever settles, and thereafter de-escalate to oral antibiotics. But initially, in these very young children, it is safest to give parenteral antibiotics. So it depends on the age of the child, then the severity of illness. Of course, if they are toxic and ill-looking, etc., and they are vomiting and not able to tolerate oral medication, you should admit the child for intravenous treatment. Okay. If they have any severe urological abnormality or underlying medical comorbidities, now the child is immunosuppressed, like child is HIV positive, or you have a child with malignancy or any other comorbidity that is severe enough to immunocompromise the child, then if the child has got a fever, etc., even if it's not high, I would suggest that for a few days you start intravenous antibiotics. Of course, non-adherence is, as I discussed previously, is one of the other factors that we will use for admission and intravenous antibiotics. If you find a child with severe pyelonephritis, you should treat for at least 10 to 14 days. Now that's the recommendation that is given by most of the consensus statements. That means the NICE guidelines and even the Italian and the Swiss guidelines. However, if you look at the TEDUCA guidelines, they tell you that shorter courses of antibiotics may be effective. So there is, as I said, there is no strong evidence to show that you should be doing this. But I think in a child that is very ill, etc., I would definitely give them a reasonable course, at least between 7 to 10 days of antibiotics, whether that be oral or intravenous. What about the difference between the two, whether it's oral or parenteral antibiotics? In children greater than 3 months, both have been shown in the literature to be equally effective. So as long as the child can tolerate the antibiotics, etc., especially if you are using antibiotics that are well absorbed, then it is safe to do it. The problem with some of these oral antibiotics, especially the ones that we commonly use, like clavulanic acid together with amoxicillin, which we call augmentin, and if you look at the cotrimoxazole, some of them don't have very good absorption rates. And so in the first few days, I would suggest, if the child is ill and toxic, start with intravenous antibiotics and then scale down to oral. This is a summary of the treatment recommendations based on the European guidelines. So they say begin parenteral antibiotics in a child less than 2 months old, or who is very quite ill looking. That means is septic, vomiting, or has poor feeding. And once a culture is available and you know what the sensitivity is to particular antibiotics, change to that particular antibiotic, right? If on the other hand you have multi-drug resistant pathogens, right, then you have to discuss this with an infectious disease specialist, because like in our hospital, there are certain antibiotics that we cannot authorize. It has to be authorized by the ID team, right? So you have to revert to using that. You should not switch to oral therapy in the event of an inadequate response to parenteral therapy, or if the child is still vomiting or is persistently ill, right? In children with an acute or chronic kidney failure, have severe urological malformations, or you have neurogenic bladder or some foreign material that's present in the urinary tract, the optimal management strategy should include initial parenteral antibiotic therapy. And once a child has settled and there's defervescence and the child is not ill looking and toxic and is able to tolerate oral treatment, you can switch over to oral antibiotics.
On my screen,
so those are some of the indications that we would use for parenteral antibiotics. Okay.
Ndo nimeona, unajua nimefikiria hii video nikikutumia mtu mwingine anaweza iona kuambia mtumie.
Okay. What are the treatment options that we have? Some of the antibiotics that we commonly use, the ones in yellow are the ones that I commonly use in my unit. If you have upper urinary tract infection and I want to use oral antibiotics, the commonest one that I use is either amoxicillin clavulanic acid, which is augmentin, or cefuroxime. Cefuroxime is a second generation cephalosporin, and I find it very useful for 2 reasons. In our setting, we looked at the resistant patterns, and at least about 60% of the E. coli that we have are resistant to amoxicillin. Okay, so if we have to give an antibiotic, I usually use amoxicillin with clavulanic acid. But why I like cefuroxime is because of the fact that it is mainly renally excreted. Okay, there's very little gut excretion. Okay, so you get high concentrations of the antibiotic in the urinary tract. Okay, If on the other hand, we have urosepsis or pyelonephritis in the older child, then I might use a combination, either depending on how ill the child is, of either amoxicillin clavulanic acid together with an aminoglycoside, or cefuroxime together with an aminoglycoside, okay? And then depending on what my culture shows, and then switch over to the appropriate antibiotic if it's sensitive. Now, the only, of course, the one thing that you have to is the function test. Okay, if you find a child has compromised kidney function, then you try not to use aminoglycoside. Okay, then I would just use cefuroxime, and based on the culture test, I would then switch over to the appropriate antibiotics. If you have lower urinary tract infections, once again, we have a pretty high resistance rate, except in the very young child, the neonates, for to sulfur drugs, okay? So trimethoprim and sulfamethoxazole, which is Bactrim, okay? So in the neonates, we don't use Bactrim because of the side effects of the sulfur. So if you have trimethoprim available on its own, then use that. But I generally tend to stick to either amoxicillin, or if the child is ill, I use cefuroxime. But as I said, it's very difficult to diagnose a lower urinary tract infection in a young child. So most of the time, if they are ill, etc., I treat them as if they have a upper urinary tract infection. How do you follow up following the course of treatment? Okay, once you started the antibiotics, you've done the dipsticks, you sent off the urine for culture, etc. I usually review the child within 3 to 5 days. And by then time, the urine culture is back. And then depending on the sensitivity of the organism, if anything is cultured, you will adjust the antibiotics accordingly, right? If you don't find any growth on the urine, then you should look for an alternative source of infection. And of course, if you have complications such as pyelonephrosis, or you suspect a perineal abscess because the child has a swinging temperature, etc., you must do an ultrasound. All children should have this, okay? And I'll discuss imaging just now. So that is just how you would start for the initial attack of urinary tract infection, and follow it up with culture, adjust the antibiotics appropriately. And then depending on how ill the child is, your length of antibiotic treatment, whether it's intravenous or oral, will vary, right? Usually the recommendation is, if it's a very ill child who's toxic, etc., 10 to 14 days, or in a child that just got a lower urinary tract infection, you can treat 5 to 10 days, okay? But definitely the literature shows that you shouldn't use single course of antibiotics. That's why you don't give a stat dose of any particular drug and hope that the urinary tract infection is better, okay? It's not recommended. However, the length of treatment is still something under discussion, right? Many people have given 3 days antibiotics and found is as effective on intention to treat as giving 7 days of antibiotics. But so far guidelines have varied. Some guidelines say 7 to 10 days, others say 5 to 7 days. And so it depends on the response of this child. This is just an algorithm for treating, but what I put this down just because when you read it, this is what the consensus statements show, that if you have a child less than 3 months, you should do a urine sample and send off to the lab and then initiate treatment. What's missing in this whole algorithm is, of course, the dipsticks, okay? I like dipsticks as a screening test, okay? If the screening test is negative, even if in a young child, I always look for another source of infection. But always, if you suspect a urinary tract infection, as I said, the only thing that makes a diagnosis is a urine culture, okay? I'm not going to go into details of this because of time constraints. So I'll send the presentation through, Floyd will distribute it to everyone, and then you can read up on that, right? Then the question comes, pediatricians used to do a lot of imaging studies, okay? In a child who's got a urinary tract infection, I don't know what the adults do, but in the most recent literature in the last 2 decades or so, less is better, okay? And if you look at that second picture, on the picture on the right-hand side, every child that had a urinary tract infection underwent a voiding cystourethrogram, okay? And you can see how this child is complaining, okay? It's traumatic, it's distressful. Yes, in an older child, it is demonizing. You don't, they feel shy, okay? Just like adults, okay? And it's some people have described it almost like sexual abuse. Okay, right? I won't put it so strongly, right? But the driving force for the correction of vesicoureteric reflux is definitely not one that should coerce us into doing voiding cystourethograms readily, okay, or very easily. So unless we have a strong indication for it, I would suggest we stay away from it. However, the one test that is easy to do, simple, non-invasive, and without side effects, and it's readily available. I'm not sure how it is, how available it is in your setting, but in my setting, it's very easily available, is the ultrasound, okay? So ultrasounds are very easy to do, and the thing about it is that it's operator dependent, okay? So unless you are trained in ultrasound and know how to image the kidney, etc., it can be a problem. But we are fortunate, we have resident trained radiologists, and so they are able to do it very quickly. So this is the one investigation that I think that every child with a urinary tract infection should have. That is an ultrasound, okay? So let's go into imaging studies better. If you look at kidney and bladder ultrasound, it should be performed during the acute phase of infection to identify structural abnormalities. That means, especially if you have features of an atypical urinary tract infection or in a child with recurrent urinary tract infections. If they're not present, if those things are not present, then an ultrasound can be performed even at a later stage, okay? However, the last statement is the most important, that every child, regardless of age, even if it's the first attack of urinary tract infection, should have an ultrasound done to exclude any major abnormalities of the urinary tract. It's easy, it's cheap, it's simple, and free of side effects, so there shouldn't be a problem, right? The only problem in a very young child is to get them to cooperate, and often I just sedate these patients, and it makes it easy for the radiologist to do that. Voiding cystourethograms, as I said, these were done very frequently previously. However, nowadays, we only do it if we suspect there is a high grade of vesicoureteric reflux. That means grade 4 and 5, right? And if you have grade 4 and 5 reflux, usually pick it up in your ultrasound with dilated ureters, dilated with hydronephrosis, right? If you suspect posturethral valve in a male child, and if there's bladder and ureteric anomalies, like if you're suspecting a uretrocele. So those are the things, those are the indications only that you should do a VIII, because it's quite a traumatizing experience for the child and for the person performing it as well, okay? So unless you are sure that you want some very critical information, try and avoid doing it. The timing may be performed as soon, you must only do it if your urine culture is negative, correct? If you do it without checking your culture and your treatment isn't working or it's not sensitive, etc., and you do a VIII, you might disseminate the organism. And I had 2 children who ended up with a septicemia because the staff unfortunately ordered a VIII and they didn't check the urine specimen culture results, and the child still had an active growth of bacteria in the urine. And this study was done, and the next day the child started spiking high fevers, etc., and needed to be transferred to high care for intravenous antibiotics. So it can be a problem if you do it. So always check the urine culture to make sure it's negative before you do a VIII. There was this story previously that VIIGs must not be done during the acute phase of a urinary tract infection, because at that stage the uroepithelium and everything is inflamed and you have a lot of edema, and therefore the child might have reflux that is not really there, or you may not detect it. That is now no longer true, okay? You can do a VIIG within 8 days of starting antimicrobial as soon as you have a negative, and it makes no difference, right? The other question is, if you have a child whom you suspect got a urinary tract infection with a congenital abnormality on ultrasound, you want to do a VIIG, and you're not sure whether to start this child on antibiotics or not. The new recommendation is that you should give antibiotic prophylaxis before you do the VIIG, and you continue it up to the time that you finish the examination, okay? So if you have a child who you suspect has a congenital abnormality based on, say, prenatal screening, okay, or you will then say that, okay, we're going to do a VCUG, but we're going to delay the study because we want the child to be older, etc. Until the time that you do the study, you should put the child onto onto a prophylactic antibiotics. And once you finish the study, you can then stop the antibiotics. So that's the recommendation. So this is the indications for doing a VCUG. What the most common is if you find any congenital abnormality of the urinary tract based on your ultrasound findings, right? Whether there's unilateral or bilateral renal hyperplasia, increased renal echogenicity, if you find hydronephrosis or urethral dilatation, or you find urethral thickening, or any bladder abnormality where you suspect a diverticulum or retrocele. Those are absolute indications. The other one is if you find an organism other than E. coli, atypical urinary tract infection, okay? So that may be an indication for doing it, right? So as you can see, there are very few indications in which we do VCU. Every child who presents VCU should not have a VCU unless your ultrasound shows any of these things. So you can eliminate a lot of children, okay? So we've avoided doing VCUGs in a lot of children, okay? Ultrasound, on the other hand, I would strongly recommend be done in every child because it is readily available and it's free of any side effects, okay? Now, there are other types of imaging studies that are done like nucleotide scintigraphy, etc. I'm not going to go into that because we don't have it available in our hospital, and I don't know what's the availability in your center, but definitely it's not something that's readily available, so I'm not going to discuss that in any great detail, okay? The other indication for VCUG is, of course, if you have recurrent urinary tract infections, right? Abdominal X-ray. This is something that often many people forget, okay? And like I said, if you take a history from the parents, when you ask them what's the child's bowel habits, they tell you, no, it's fine, doctor, right? But if you do an abdominal X-ray, you'll find in several of these children fecal loading, okay? And that's strongly suggestive of bladder bowel dysfunction. And when you get bladder bowel dysfunction, that often predisposes to recurrent urinary tract infection. So please always think about this, right? And it doesn't cost much to do an abdominal X-ray. Now, what about scintigraphy? That means a DMSA scan, okay? I didn't go into MAC3 scans, etc., because that's hydronephrosis and everything else, and that's a separate topic. But in urinary tract infections that are recurrent, right, you do a DMSA scan. Now, DMSA scans previously done in both the acute phase and after a period of time to detect renal scarring. However, new literature shows that DMSA scans should not be done routinely during acute phase of urinary tract infection. Right? Now, remember, 9% of acute pyelonephritis can have culture negative findings on urine culture. Now, if you strongly suspect urinary tract infection and you can't find any other focus of infection and the child has severe urosepsis and you still think the kidneys are involved, then when you should do the DMSA scan is usually after 6 months, right? And like I said, the most important indication is to detect scarring, okay? Right. Sometimes we also use it for looking for other things like a non-functioning kidney or hypoplastic kidney, etc. But in the setting of UTI, the most important indication is to look for scarring of the kidney. Right. Now, what about long-term antibiotic prophylaxis? Right, we're running out of time. In general, this is not recommended, right? There are very limited indications. The limited indications are if you have children with complex congenital abnormalities of the kidney or urinary tract or some type of underlying bladder bowel dysfunction. If you have high grades of reflux, that means WHO grades 4 and 5. And of course, as I said, before you do avoiding cystourethrogram, if it's delayed for some reason, say the radiology department is not ready or the child is being treated for something else, or then as long as you haven't done a VCUG, you should put the child on prophylaxis. And of course, once that is over, you can terminate the antibiotic treatment. What are some of the side effects of using long-term antibiotic prophylaxis? Of course, the commonest one is antibiotic resistance. And of course, it interferes with the intestinal microbiome. And if you interfere with that, you can interfere with your immune system, okay? And so therefore, except for the indications that I listed there, antibiotic prophylaxis is not encouraged as for be used in urinary tract infections, except in those settings where you've got severe congenital abnormalities of the urinary tract, or you've got high grades of reflux, etc. Right? And you should review it every 6 to 12 months because of antibiotic sensitivity. One thing you must remember, that continued antibiotic prophylaxis does not influence the recurrence of urinary tract infections nor the incidence of kidney scarring. Okay, right? It is something that you must always bear in mind. Now, you can't talk about antibiotic prophylaxis if you don't talk about these two studies, the Swedish study and the reverse study. That means randomized intervention for children with vesico-ureteric reflux. These were two large studies that were done. The second study was done, one of my colleagues, he is Mather from, I think, Wisconsin, okay? And he did a very large study. That the study I'm talking about now is the review study, the second one, where he used prophylactic trimethoprim and sulfamethoxetol. And what he did found that he significantly reduced the incidence of urinary tract infections in children 2 to 71 months old with grade 1 to 4 of vesico-ureteric reflux. And this was much more common in females, especially if they had bladder bowel dysfunction. Now, this finding was a bit unusual because the first study, and that's why I mentioned this study for the second study first. The first study showed that the incidence of recurrent urinary tract infections and kidney scarring was reduced only in female with grade 3 to 4 of vesico-ureteric reflux when they were given continuous antibiotic prophylaxis over a 2-year period. So there's a slight difference in the findings here, right? At the moment, still there is no consensus on how long you should give it, how much you should give, but we do know that particularly in females, especially if they have bladder bowel dysfunction and if they have recurrent attacks of UTI and they have some cackle or something, then there may be a place for continuous antibiotic prophylaxis. Some studies, smaller studies, have shown no difference, okay? But then they always tell you that, you know, the study was underpowered, so you really can't draw any conclusions from those studies. What's the choice of antibiotics you use? Like I said, in the neonatal period, if you have trimethoprim that is being used, right? And then it also depends on the sensitivity patterns locally, okay? To prevent development of resistance, you shouldn't use beta-lactams and quinolones for long term. What about urinary antiseptics? In the older child, this can be used. The two that are commonly used are nalidixic acid and nitrofurantoin, okay? But the most common use prophylaxis at the moment is still trimethoprim sulfamethoxetol. So just to conclude then, the vague clinical presentations of urinary tract infection in children requires the doctor to have a high index of suspicion, especially in young children presenting with fever where there is no obvious focus of infection. Antibiotic therapy should be given for at least 7 to 14 days, depending on how ill the child is, and of course should be based on urine culture results. Oral antibiotics have been shown to be as effective as intravenous antibiotics, but the latter is preferred if the child antibiotics or is very toxic and is ill with severe vomiting, etc. So in that case, hospitalization and intravenous antibiotics is absolutely indicated. With regards to imaging, as I said, every child should at the minimum have an ultrasound. However, if you want to do more imaging, like voiding cystourethograms, etc., or scintigraphy, that means DMSA scan, then this should only be done in children who have complicated urinary tract infections or you suspect some type of cackle. Okay. Remember, bladder bowel dysfunction is being increasingly acknowledged to be of high importance in children, especially with recurrent UTIs and those with asymptomatic bacteriuria. I haven't spoken about asymptomatic bacteriuria because that's something different, but bladder bowel dysfunction is very, very important and you must not underplay its role. And I would suggest, apart from the ultrasound, if your ultrasound doesn't pick up any constipation, etc., and the child has more than one attack with UTI, you should do a straightforward abdominal X-ray looking for this and always take a history from the parent. So I'm going to stop there and tell you that if you have any questions, it is a very large topic and I'm a little bit over time, but then I started a bit late. Sorry about that. So I'll be happy to answer them. But like I said, if you look at all the diseases in pediatric, this is one of the most controversial topics. And the more you read consensus statements, the more confused you become. Okay, so I'll leave it at that. Thank you very much. I think you're muted.
Thank you very much, Professor Bhimma. This is really nice talk, and it is quite exciting. And as it is always the case, UTI can be quite challenging, and unfortunately, sometimes it is taken as a scapegoat. That every time a child comes with fever, people usually tend to think that it is UTI, and they will look for all the evidences just to give antibiotics.
Yes.
Yeah. So may I welcome members of the panel if they have any questions? I think there are some questions that were posted in the chat. Yeah.
Okay.
So I guess we could start looking at those.
Okay. Okay. So the first one was, let's classify the relationship between UTI and constipation and swimming and UTI. Okay, like I said, if you look at all the new publications that are coming out in the pediatric literature on UTI, bladder bowel dysfunction is becoming increasingly more prominent, right? And we should actively look for this, okay? And taking good history from the parent, even observing the child when they go to the toilet, etc., or getting an abdominal X-ray is very important, because when the child strains the stool, what happens? They contract the muscle, and that forces the bacteria from the peritoneum back into the urethra. Okay, so most urinary tract infections in children, as you accept in a neonatal period, are ascending infections. Okay, so I think we must actively look for that. Swimming and urinary tract infections, this is another thing that is in the literature. If you have clean pools, that means the pools are tested for the E. coli counts, etc., and they are appropriately treated, then it is less of a problem. But in children using pools that, like especially public pools, which are not properly screened and tested, it can be a problem. Okay, and I always advise my patients that if you have a child, especially if it's a female child or uncircumcised male, etc., and they're swimming in a pool that is not properly tested, then they can predispose to UTI. Does that answer the question? I don't know who sent the question. Matoya. Hello? Okay.
I believe if they have follow-up questions, they will ask.
Yes. Yeah, okay. Then there was a question, there's a belief that using dirty toilets, especially public toilets, can predispose someone to infected UTIs. Is that true? The answer is yes, okay. I didn't bring this up, but I should have. Prevention. You know, what are some of the advice I give mothers? Firstly, that if there's constipation, or you feel that the child is not emptying the bowel appropriately, I always put them on a stool softener, okay, and charge the mother to change the diet to a high roughage diet. Second thing is advise them about swimming and pools, etc. The third thing for urinary tract infection is water. Okay, ask the mother to increase the amount of water intake, not fluid. You tell the parent increase fluid intake, the child is happy because he starts drinking more Coca-Cola or start drinking positive drinks. That's not good, okay? Because those things have acidic, you know, the CO2 converts to acid, okay? So increase fluid intake. The other thing was what was brought up is you advise parents that if they're using a bathroom outside the home, etc., especially in a public area like shopping malls, etc., carry sanitizers and teach the child to squat rather than sit on the pan, okay? Especially female children, okay? Because they are small, they can easily squat on the seat, okay? And when they then relieve themselves, there is no chance of them getting contamination from the toilet seat, etc. But always sanitize the area, okay? Fortunately, in some of the better malls, etc., we have sanitized toilets in our setting, but if that's not available, you always ask them to carry a sanitizer and do that. Then other thing that you always tell them to do is that to teach the children to avoid frequently. Okay, children get busy with play, etc. They hold, and when the bladder pressure builds up, there's fossil bacteria back with the due to reflux. So that is some of the advice that you give them, and you're absolutely right that clean, dirty toilets can predispose to it. What is the long-term prognosis of developing chronic kidney disease in uncomplicated recurrent UTIs in girls? The jury is still out on that. There's been no strong evidence based on recent studies. Previously, it was thought that if you get recurrent UTIs, of course, and severe scarring, then that goes to chronic kidney disease, and the incidence is very high. But at the moment, because I guess we are picking up more UTI, we are screening for it and treating it early, etc. The incidence of chronic kidney disease leading to end-stage kidney disease, or what we call chronic kidney failure, is pretty rare following UTIs. Okay. However, the risk is still there. That's what the literature says. The risk is still there, and therefore we should treat UTIs appropriately. Okay. So I hope I answered that question. Can you please comment on the childhood UTIs and adult renal disease? Okay. So this was the thing that was brought up, that if you get recurrent UTIs in childhood and you get renal scarring, that will predispose to things like hypertension, chronic kidney disease, and end-stage or chronic kidney failure in adulthood. You know, the studies that were done were older studies. I've scanned the literature for newer studies. There's still one study that's carrying on. I think that's a Swiss study, but their incidence was less than 2%. Okay, so that risk from being a very high risk from previous literature is now reduced to a very small amount, and that's, I think, because of better a high index of suspicion, more availability of antibiotics, better screening, and better imaging, etc. And so we are able to treat UTIs better. So yes, the risk is there for developing chronic kidney disease in adulthood, but it is at the present moment reduced to a minimum because of better treatment in childhood. Use of nitrofurantoin for childhood UTIs. I do not use nitrofurantoin in patients who are very young because of the possible side effects. Okay, and I'm not going to go into, but I generally reserve this for my adolescent patients. Also, dosing is a problem. The problem with nitrofurantoin is that it comes in a capsule form. I think the minimum dose is 50 milligrams. And if you work out the recommended dose for prophylaxis is 2 milligrams per kilogram. And in a young child who's 10 kilograms, you can't give 50 milligrams. Okay, so the problem is the child to swallow the capsule. The problem is to get an appropriate dose, and therefore I do not use it in very young patients. I reserve it for adolescent patients. What about fungal UTIs? I didn't just touch on this because that's an atypical urinary tract infection. And yes, if you have fungal UTIs, they occur in special settings. Okay, the most common setting we find it in is patients who have AIDS, patients who have malignancies, patients who have long catheterization, and then patients who have other surgical procedures done, like if they have nephrostomy tubes placed in for a long time. And some previously, well, nowadays we don't do it, but patients who had this, what you call vesicostomy done, or a uterine. Okay. So there's patients who have some to the urinary urinary tract, if they have a catheter placed in a long time or severely immunocompromised. Those are the patients where you get fungal UTIs, and those are the patients which used to screen for fungal infections. Okay, and good thing is that when we send urine for culture, etc., the microbiologist always screens for fungal infections. And if we strongly suspect it or we diagnose it, then we treat them with antifungals. Okay, but of course, the most important thing is try and correct the underlying abnormality that predisposed it. Recommendations for urinary tract prophylaxis, I ran through that in my talk, so I won't cover that. Recurrent UTIs and infertility in women, that's a hard one. Okay, the answer is I don't know. Okay, I didn't find that in the literature, and I don't know if there's any evidence for it. So I have to pass on that one and come back to you, because I have not come across anything in the literature that showed that recurrent UTIs predisposes to infertility. But as I said, I'm not sure about it. Okay, I haven't come across it. What about children with severe acute malnutrition who do not present with fever or vomiting, and when you do urinalysis, you must always turn positive for UTIs? Can you explain? Yeah. Okay. So in our setting, okay, particularly in our Black patients, etc., we used to find a lot of urinary tract infections in malnourished children. Okay, and it was, in the Western world, it is mainly due to vesicourinary reflux. Now, the study done by Prof. Kaladem from Wits University showed that our Black patients have a very low incidence of vesicourinary reflux. However, the one thing that does predispose them to urinary tract infection is diarrhea. Okay, you get swelling, and so their child may not have a nappy chain for a long time, etc., and sitting in a pool of poo which is contaminated, full of E. coli, and of course easily gets UTI, or malnutrition, okay, which immunocompromised. So yeah, those are the two settings. So you can get that. The problem is in malnourished children, if you do a screening test like a dipstick, you might not find leukocytes or nitrites, okay, because of the fact that one, the child is voiding very frequently, two, there's diarrhea and contamination, and thirdly, of course, that being malnourished, they don't mount an immune response. Right? So that's it. Next question, what is your comment on the urine culture and sensitivity on the time of urine sample collection? Some laboratory technicians will request morning urine specimen. Okay, this is different from schistosomiasis, right? At one stage we should say that you should do the urine culture like you do blood cultures at the height of the fever, etc. Presently, the literature doesn't advocate that. So what it does advocate is that if you are taking urine for culture, the collection method shouldn't be a bag specimen, either a clean cat specimen or an in and out catheter. The best, of course, is suprapubic, but that has to be done by skilled personnel. The second thing is that if you are sending the urine for culture, you should not leave it standing for a long time, right? And they quote 4 hours. Okay, so the urine should be cultured. If you are not able to transfer the urine to the laboratory in time within that 4-hour period, it is strongly recommended that you refrigerate the urine, right? And in that way, at -70 degrees, you prevent proliferation of bacteria. Okay, so that should answer that question. Then, is there a role for urinary acidification to prevent large bacterial growth in children? There's nothing in the literature to suggest that you should use these things. Okay, I know parents use a lot. I didn't speak about it. Alternative methods of treatment. So one of the questions that I get asked is, by mothers, is cranberry juice. Yes, that's the thing I'm looking for. Cranberry juice, does it help your child to prevent? And there's 2 studies that showed some benefit, but other studies show no benefit. So once again, I think those 2 studies were underpowered, and the statistics were a problem. Okay, because it was small samples, so wide confidence intervals, so you can't trust those p-values. Okay, so the answer is no, there's no use for it. Use of vitamin C, there's nothing in the literature that shows that vitamin C has an effect on urinary tract infections. What is your experience with tuberculosis of the urinary tract? Okay, once again, tuberculosis of the urinary tract, the Cape Town people did a lot of work on HIV positive patients. They found a TB of keys in many of these patients who had diagnosed with HIV nephropathy. I must say, in Durban, we did biopsies on a lot of patients with HIV nephropathy. Okay, and we published this in, I think, Pediatric Nephrology, one of the largest series. Okay, and we didn't find TB in any of our patients. Okay, for some reason, my colleagues in Cape Town seem to have a high incidence of TB, especially in adults in their biopsy specimens. So yeah, so HIV and UTIs, does HIV predispose to UTIs? We did a study. I didn't bring it up, but I think it was published in one of the channels. I forgot which channel it was, but anyway, it was by Dr. Asharam et al. And when we looked at HIV and UTIs, we didn't find that HIV predisposed to UTIs, except in those patients who were severely ill, like AIDS patients, etc., who needed to be catheterized and were in the ICU setting. So yeah, HIV, if it's properly treated, etc., there's no higher incidence of UTI. Okay, that's answered some of the questions on the chat. Anyone else?
Yes, Prof, there's a question that is asking, what is your comment about the lab report that says motile bacteria were noted?
Motile bacteria.
Yes.
That's on microscopy. That must be a very fresh specimen, okay? Live bacteria in it, okay? I don't know, I haven't seen that report, but it's difficult. I mean, obviously they will culture that, and then based on your culture, you see what bacteria it is, and then work out the sensitivity. But I haven't seen a report which shows motile bacteria. Okay, I mean they say bacteria. Cool, but of course, if you are looking at it, when I was training, we used to do what we call side room techniques. So we used to collect the urine and immediately look at it under the microscope in the side room. Okay, we had a microscope that's gone now, right, in the new hospital. But when we did that, we used to diagnose schistosomiasis and E. coli and all of them. Yeah, then you can see motile bacteria. Okay, if you do what you call it stain. But in the routine cultures that we send to lab, etc., I've never seen that. Okay, so I don't know how to answer it. But definitely you culture it, and whatever sensitivity you find, you treat appropriately. Okay.
Yeah, thank you, Prof. So that was one of the last questions in the chat.
Okay.
Yeah.
All right.
So I guess if we don't have any other questions, this has been really a wonderful presentation, and we have learned a lot from this presentation. And I guess the only comment that I would like to say is the fact that as Prof said, it is important to get your specimen before you start antibiotics, because you can always get a poor response and you might need to revisit your treatment. So it is always important to get your specimen, send it for culture before you start antibiotics. And the other important thing is the fact that you have UTI, make sure that you do an ultrasound just to see if there's any abnormalities. Absolutely. So thank you for reminding us about that.
And just remember one other thing, always look for bowel dysfunction. Okay.
Yes, indeed. Okay? Indeed.
And treat that appropriately. And I think if we do those three things, as you mentioned, we'll go a long way towards preventing all the other complications, so that we don't give our adult colleagues a bad person who's entering with chronic kidney disease. Okay.
Yeah.
All right.
Yeah. So, I mean, to answer your questions about the access to ultrasound, I think we have pretty much good access to ultrasound in most of the tertiary level settings.
Yeah.
So I would say that it's readily available. We'll be able. The only problem is the fact that it is the operator dependent. It depends who is looking at the bladder, and I guess it's also challenging when you look at the kids and the children. The radiological findings are a little bit different from when you look compared to adults. So sometimes you might be people might be telling you that I see some echogenic kidneys in infants, and which might be normal. So that's one of the challenges, that it is operator dependent.
Obviously, but we do need a trained sonographer.
Yeah. So I guess Dr. Lloyd, do you have any questions that you might or comments about the presentation, please?
I think it was a wonderful presentation, Professor Bhimma. Excellent presentation, extremely well covered. It was very rounded, didn't leave anything out. I think these topics are extremely important, especially for the pediatrician to know. And we will have I think it's very important to have these pediatric topics on board, not just the adult topics in nephrology. And I call upon Dr. Francis and yourself, Professor Bhimma, to actually form a list of topics, and we can have it at least once in 6 months, a good pediatric topic which is of value to pediatricians. And if you both of you all can suggest it, and it'll be really wonderful, actually. Yeah, it'll be wonderful. It's nice. Thank you so much, Professor Bhimma, and
thank you very much for everyone that attended. I hope it enlightened you a bit. I must say that there's a lot of other nuances, but I didn't touch on because of time constraints. I didn't go into complicated UTIs and asymptomatic bacteria, but I think this covers the gist of what we need to know. Okay. Thank you very much. Okay.
Thank you very much.
Bye.
Yeah. Thank you very much, and thank you, everybody. Yes, I think it was really good. Yes, and I want to thank everybody for participating, and I think I would wish everybody a nice evening for those that are in the evening, as myself. Yes. Yes.
Thank you so much.
Yes. Thank you so much for organizing this, and bye everybody.
Bye. Bye, everyone.
Bye.
Thank you.
Bye. Okay.
Thank you.